Continuing with our module on pediatric anesthesia, the third lecture in this series is on video-assisted thoracoscopic and laparoscopic surgery. Laparoscopic surgery in neonates as well as children is gaining popularity because of its many advantages like causing minimal tissue trauma, decreasing the post-operative pain, producing a shorter hospital stay, and an earlier return to normal activities. The surgical procedures which can be performed range from a cholecystectomy in older children to pyloromyotomy performed for an idiopathic hypertrophic pyloric stenosis in neonates. The introduction of robotically controlled instruments to facilitate laparoscopic surgery has expanded the number of surgical procedures which can be performed for these group of patients. These surgeries are mainly performed for urological surgery. The surgical robots provide a three-dimensional stable visualization of the surgical field by eliminating the counterintuitive movement with conventional laparoscopy, thereby providing a fine control of the laparoscopic instruments. The Da Vinci surgical system, currently the only robotic system approved by FDA, is the one which is commonly used. The robotic system consists of a master console. It consists of a robotic arm which has one camera arm and three port arms and a vision cart. The laparoscopic or the robotic procedures can be performed via transperitoneal or retroperitoneal approach depending on the surgeon's preference. In the case of a transperitoneal approach, the abdomen is insufflated through a port which is placed below the umbilicus so that a working space may be created. The additional ports are then placed depending on the type of surgery which is being performed. The robotic tower is then brought to the side of the patient and the robotic arms are engaged to the ports. The transperitoneal and retroperitoneal approaches have comparable surgical outcomes in terms of risk of bowel and vascular injury. However, the transperitoneal approach has certain advantages. It is usually performed in the supine position and it gives a large working space and provides a natural orientation to the anatomic landmarks. The retroperitoneal approach is usually performed in the lateral or the prone position. It has advantages of a quicker and safe port placement, visceral handling with lesser risk of injury, more rapid access to the renal pedicle, and easier renal artery control. It also leads to less analgesic consumption. However, the retroperitoneal approach leads to more carbon dioxide absorption because it is a vascular space. It contains areolar tissue which offers less barrier to the carbon dioxide absorption. It also elevates the peak airway pressures and also increases the cerebral blood flow velocity. However, these disadvantages are relevant only in children with cardiorespiratory compromise and those with CNS pathology. Whenever you want to perform the laparoscopic or a robotic surgery, you have to insufflate a gas into the peritoneal cavity. Now, an ideal gas should be the one which is incapable of supporting combustion. It should produce limited systemic absorption and limited systemic effects if absorbed. It should be rapidly excreted, should be highly soluble in blood, and it should cause limited physiological effects with intravascular systemic embolism. Based on these criteria, carbon dioxide is the best as it meets nearly all the properties of an ideal gas. The only drawback with carbon dioxide is that of vascular absorption across the peritoneum. Air, oxygen, and nitrous oxide support combustion and are therefore not used. Helium is a good gas but expensive. Also, in case IV embolization occurs, its relative insolubility can lead to cardiovascular collapse. Now, if you want to give a safe anesthesia to a child who is undergo laparoscopic procedure, you need to understand the pathophysiological effects of carbon dioxide insufflation. Now, whenever you produce a pneumoperitoneum, it produces its effects via on the various organ system by two methods, via physical pressure and via systemic absorption of carbon dioxide. The problem produced by physical pressure will be affected by the absolute amount of intra-abdominal pressure and the length of time this pressure is applied. The systemic absorption of carbon dioxide will depend on how much of the carbon dioxide which has diffused in. The amount of carbon dioxide which diffuses across the peritoneum and into the bloodstream depends on the fixed law according to which the amount of carbon dioxide diffusion depends on the area of the membrane in contact with the gas and with the difference in partial pressure of gas across the membrane as well as a diffusion constant. Now, because of this, the diffusion will be directly proportional to the solubility of the gas and inversely proportional to the square root of the molecular weight of the gas as well as the thickness of the membrane. The transpulmonary pressure is the difference between the alveolar and the pleural pressure, and it is injurious to the lung parenchyma. An increased transpulmonary pressure is likely to cause lung injury as well as the development of the ARDS. When you do a pneumoperitoneum, it increases the external pressure and thereby the pleural pressure. Based on this, the transpulmonary pressure is decreased, which allows for a safe increase in the ventilatory pressure proportional to the pressure provided. Now, carbon dioxide absorption, which is increased in case of laparoscopy, produces hypercapnia, especially if the procedure is more than 1 hour, is of more than 1 hour. Now, what this hypercapnia does is that it stimulates the sympathetic nervous system, leading to tachycardia and hypertension. It also sensitizes the myocardium to the arrhythmogenic effect of the when inhalational agents are used. The carbon dioxide which is absorbed takes some time for it to be removed from the body, and it keeps on eliminating for 10 minutes after deflation. This leads to a difference between the mean arterial and the end tidal carbon dioxide ranging from 0.8 to 8 millimeters. What is the effect which the carbon dioxide absorption produces is magnified in children. This is because of mainly an increased peritoneal surface area to mass ratio, decreased peritoneal thickness and low quantity of peritoneal fat, as well as less distance between the vessels and the serous surface. It is also to be noted that an IAP of less than 10 millimeters of mercury causes more of CO2 absorption. Whenever you do a carbon dioxide insufflation into the abdomen, it produces an artificial pneumoperitoneum, which leads to a splinting and capillate shift of the diaphragm. Because of this, there is a decrease in FRC and a decrease in lung compliance, increasing the chances of atelectasis. There is also increase in the airway resistance and chances of mainstem bronchus intubation. All these factors lead to an increase in the VQ mismatch, leading to hypoxia, hypercarbia, change in the ventilatory pressure with risk of barotrauma. Now, all these things, the effect of, if the patient is placed in the Trendelenburg position, all this hypoxia, hypercarbia, etc. would be worsened. If the IAP is more than 15 millimeters of mercury, it leads to a decrease in the venous return, which is primarily due to a decrease in the preload as well as because of an increase in afterload, which is produced because of the compression of the IVC and the collaterals. This decrease in venous return will decrease the cardiac output and lead to hypotension. This is presents in the form of increase in systemic vascular resistance as well as the blood pressure. In small neonates and infants, these factors will cause an increase in the opening of the shunts. Therefore, any child who has a cardiovascular pathology, the effect of the laparoscopic surgery on these factors should be taken into account. If the IEP is less than 15 millimeters of mercury, it causes an increase in the venous return, primarily due to a peripheral vasoconstriction, and because of an increase in the cardiac output. The factor responsible for this is that the blood which is squeezed out of the splanchnic venous bed will increase the venous return, thereby increasing the cardiac output. Neonates have relatively fixed cardiac contractility, and they cannot increase this cardiac contractility because they have immature myocardial fibers. They can increase the cardiac output only by increasing the heart rate. Now, these effects on the cardiovascular system will be magnified by the patient positioning. If the child is in a head-up position, it will reduce the venous return as well as the cardiac output, and all this will depend on the extent of rise in the intra-abdominal pressure. The resting vagal tone of neonates is high, and peritoneal stimulation because of the pneumoperitoneum or by placing of trocars can provoke bradycardia or asystole. An increased intracranial pressure and a decreased cerebral perfusion may occur because of an increased systemic vascular resistance, hypercapnia, head down position, and an elevated intra-abdominal pressure. These factors will be important in preterm infants who are at risk of intraventricular hemorrhage. The pneumoperitoneum causes a direct compression of the renal parenchyma and renal vessels. It increases the renovascular resistance and decreases the flow through the renal vein. The compression also leads to an increased expression of ADH, which activates the renin-angiotensin system. Now, patients who during laparoscopy may develop oliguria, and this oliguria may persist up to several hours afterwards. When a child is posted for a laparoscopic surgery, it is very important to conduct a preoperative history and physical examination in order to identify any underlying medical condition which is likely to impact the anesthetic management. The laboratory investigations which are required depend on the clinical problem the child is having. Blood loss during laparoscopic procedures is minimal. However, there is always the possibility of damage to blood vessels as well as opening up of the abdomen. Therefore, blood has to be made available. One can perform baseline hemoglobin, an RFT if the child is having some kidney disease, and a liver function test if the child is having a liver disease. Healthy children do not require ECG or X-ray when you have to do this laparoscopic surgery. The pre-medication is usually not required in neonates. However, older children more than 1 year of age will require oral midazolam so as to decrease the anxiety. In certain children, a high flow nebulization of a bronchodilator and anticholinergic may be required, especially in children with airway reactivity. Aspiration prophylaxis with H2 antagonists and motility agents is required in children undergoing abdominal surgery and those with abdominal distension. Anticholinergic agents are usually administered to dry the secretions, blunt the cholinergic mediated airway reactivity, as well as prevent bradycardia. This is usually practiced by a lot of anesthetists. In case of neonates, one should always check the intravascular volume. The anesthesia management of a child with laparoscopy, as well as those undergoing robotic surgery, includes placement of 2 IV lines with long extensions. The second IV line is required because when you want to do a rapid placement of a second IV line in case of an emergency, it would be very difficult in a child who is undergoing robotic surgery. Also, this extra line can be used as a drawing line for measuring the intraoperative electrolytes or hematocrit. The IV line should preferably be in the upper limb to avoid the slow onset of effect of drugs given in the lower limb owing to an increased intra-abdominal pressure. The children are usually induced by an inhalational or IV technique. In case of an emergency laparoscopy, you need to do a modified rapid sequence induction. The non-depolarizing muscle relaxants, opioids are like morphine and fentanyl are utilized for performing during the procedure. It is better to use cuffed endotracheal tubes, preferably microcuff tubes. An NG tube should be placed because this will help in reducing the gastric distension, which will help the surgeon in performing the laparoscopic surgery. Also, it reduces the risk of aspiration. The anesthesia is maintained with oxygen-air mixture using either of the inhalational agents, either propofol infusion using as DIVA. Children should be given PONV prophylaxis with dexamethasone and ondansetron, and at the end of the procedure, the abdomen should be deflated. Nitrous oxide should not be used because it risks the venous embolism. It will distend the bowel, hampering the surgeon's view. It also increases the risk of PONV and decreases the FiO2 which you can deliver to the patient. The children are usually kept under controlled ventilation because this will help in removal of carbon dioxide. It will also help in reducing the FRC. It will help in reducing the reduction in the FRC which is there because of an increase in intra-abdominal pressure and patient positioning. One can increase the minute ventilation by 20% and also increase the peak inspiratory pressure so that you can control the EtCO2. You can also counterbalance a decrease in respiratory compliance and increase in the resistance. PEEP is usually utilized because it counteracts the effects of increased IAP on the lower lung zones, opening them up and therefore improving the oxygen concentration. An increased FiO2 to maintain acceptable oxygen saturation may sometimes be required during surgery. Both pressure and volume controlled ventilation can be utilized. The monitoring is usually routine, including ECG, heart rate, NIBP, SpO2, EtCO2, temperature. One can also measure the inspired and expired concentration of oxygen, the air and the anesthetic agent. For robotic surgery, one can monitor the bispectral index to allow easier titration of anesthetic agents so that an early recovery can be achieved. The invasive blood pressure measurement is required because there is a large gradient between EtCO2 and PaCO2, and therefore it is important that we measure the PaCO2, the base deficit, and the electrolytes. Pre and post insufflation peak inspiratory pressure as well as the exhaled tidal volumes should be done so that you are able to understand whether adequate tidal volume is being delivered to the patient. The patients are usually placed supine or lateral. The surgical visualization is facilitated by tilting the head laterally. Therefore, to avoid the patients from slipping off the table, they should be secured carefully and firmly to the operating table with tape. The patient's head should be protected by a foam ring or padding so that inadvertent injury is avoided, especially when the robotic arm is moving, and it should be ensured that it does not touch the patient. Now, most of the time nowadays, this laparoscopic surgery is done by introducing a trocar through which CO2 is insufflated. However, in the previous years, varices needle was utilized, and if it is being utilized still, you have to be very careful because this needle can be misplaced and it can insufflate CO2 into subcutaneous, intravenous, pre-peritoneal spaces, omentum, mesentery, pelvis, and retroperitoneum. If there is a direct IV placement of the needle, it can lead to carbon dioxide gas embolism. In certain situations, a pneumoperitoneum may be produced, especially if you are doing Nissen fundoplication, where there is a dissection around the esophagus, or if the child has a patent pleuroperitoneal canal, and in case you have injured the diaphragm. You should also be careful about vascular, bowel, and organ injury. And excessive bleeding due to accidental insertion of needle or trocar into the vessels should also be looked into. Now, carbon dioxide embolism can occur and it will present as a sudden rise in EtCO2. There may also be acute hypotension, hypoxemia, dysrhythmias, pulmonary edema, and development of mill-wheel murmur. The treatment consists of hyperventilation with 100% oxygen, full cardiopulmonary resuscitation, and you should try to deflate the pneumoperitoneum. In case of an acute vascular injury, the patient will present with acute hypotension, tachycardia, arrhythmias, and cardiovascular collapse. For this, the management includes giving 100% oxygen, giving bolus doses of crystalloids or colloids or blood, turn off the inhaled anesthetic agents, and start vasopressors to maintain the blood pressure, obtain the hematocrit, and prepare the patient for laparotomy. Postoperatively, laparoscopic surgery causes less postoperative pain as compared to an open procedure. The sources of pain in laparoscopic surgery is incisional pain from where the laparoscopic ports have been placed, and it can be due to a diffuse abdominal and shoulder pain. The cause of the shoulder pain is irritation of the peritoneal surface of the diaphragm and desiccation of the peritoneum with the dry CO2 gases. The incisional pain can be managed with local anesthetic infiltration at port site by a caudal block, by giving NSAIDs and opioids. Other options include administration of a TAP block, paravertebral block, and erector spinae block. The take-home message for laparoscopic surgery is that a laparoscopic surgery in children leads to smaller scars, less pain, shorter hospital stay. It can be safely performed in all age groups, right from neonates to older children. However, when you are anesthetizing a child for laparoscopic surgery, you should know the physiological effects of CO2 insufflation and the raised intra-abdominal pressure. One should monitor the child for postoperative pain, PONV, and respiratory parameters. Now, continuing with video-assisted thoracoscope surgery, or VATS. The thoracoscopic surgery is usually performed in the neonatal period, usually for the repair of tracheoesophageal fistula, congenital diaphragmatic hernia, ligation of patent ductus arteriosus, and excision of congenital cystic adenoid malformation, that is CCAM. In older children, it is usually performed for excision of the hydrated cyst, for lobectomy or pneumonectomy. Now, when you look at these, there is a wide range of surgical diseases and surgical pathology which you will be encountering in children of varied age, right from a low birth weight preterm neonate to full-term neonate, as well as an older child. Therefore, it is very important that you understand the principles of neonatal physiology, the thoracic anesthesia, and one lung ventilation, so that you can perform a safe, effective anesthesia for these group of children. The commonest VATS procedures performed are for TEF and CDH repair. Now, if the child of a tracheoesophageal fistula will usually present with respiratory distress, because after the first feed, the child has aspirated the feed into the lungs. He will also present with drooling out of secretions since the esophagus is not patent. The chest X-ray will show infiltrates, as well as failure to pass the nasogastric tube beyond the esophageal pouch, which will be curled up. Now, what do you do during a surgical procedure? During a surgical procedure, after what you first do is you try to localize the fistula by dissection, and then you ligate the fistula. Now, after this fistula has been ligated, what you do is you try to localize the upper pouch. You try to dissect it out and see the upper pouch, and it is usually identified by the presence of the the nasogastric tube which has been passed by the anesthetist. And then once you have identified the upper end as well as the lower end, the anastomosis is done over the nasogastric tube. Now, robotic guided TEF can also be performed, and in robotic surgery, the anesthetic issues remain the same, similar to what you will find for a thoracoscopic procedure. However, there will be an added problem of remote access of the patient, since the neonate is a very small, tiny human being. Therefore, the big robot will be sitting over the whole child, and therefore, accessing the child will be very difficult. In congenital diaphragmatic hernia, the child usually presents with respiratory distress either at birth or within a few days of birth. The child will have cyanosis and poor feeding. There will be decreased air entry on the affected side. You can hear the bowel sounds in the chest, and the abdomen will be flat or the scaphoid. X-ray will show a bowel loops in the chest with paucity of loops in the abdomen. In case the stomach has been herniated, you are likely to see the tip of the nasogastric tube in the chest. There will also be mediastinal shift. Now, in the surgical procedure, usually what you are going to see through the thoracoscope, there will be a bowel loops into the chest, as well as there will be hole in the diaphragm through which you will be able to see the abdominal contents. The first thing to do is to reduce all the contents inside the abdomen, and then what you do is that you start repairing the defect which is produced. Now, thoracoscopic surgery is mainly problematic because of two reasons. One is the hypoxia and second is the hypocarbia. And in addition to this, the basic neonatal physiology is also likely to worsen the hypoxia and the hypercarbia. Now, most of the time, the cause of hypercarbia is because you are insufflating the chest with carbon dioxide, and this will lead to increased carbon dioxide absorption. The cause of hypoxia is usually hypoventilation, because when you do thoracoscopic surgery, you're collapsing the operative lung. And the second most likely cause is one lung ventilation. Now, a neonate has higher oxygen consumption and he has a smaller oxygen reserve, owing to which he's likely to encounter rapid desaturations. Now, because of this, a normal neonatal physiology contributes to this hypoxia and hypercarbia. Now, the functional residual capacity of is usually a static balance between the outward and the inward recoil of the chest wall and the lungs respectively, and this FRC is lower in the neonates. Now, because the elastic recoil of the infant lung is very less, the closing volume is usually more than the functional residual capacity, and because of this, it leads to terminal closure of the airways during normal tidal ventilation. All these produce a risk of hypoventilation. Now, collateral connections in the alveoli are present, and these are pores of Kohn and bronchoalveolar canals of Lambert. The presence of these collateral connections leads to less atelectasis. However, these collateral connections are not present till the first year of life. Therefore, up to 1 year of age, children will be at increased risk of atelectasis in the dependent lung areas. The surfactant deficient lungs, especially in preterm infants, leads to poor compliance, reduced volume, widespread atelectasis, mismatched ventilation perfusion, and therefore hypoxia. Neonates also have fewer and larger alveoli, which are at a higher risk of airway collapse. This is because since the number of alveoli is less, there is less of elastic recoil. And there is increased risk of airway collapse, especially during expiration. The infants have a highly compliant and deformable thorax, and the intercostal muscles, their efficacy is less owing to the horizontal orientation of the ribs. Both the diaphragm and the intercostal muscles have less type 1 muscle fibers, making them prone to fatigue. In congenital diaphragmatic hernia, there is lung hypoplasia, and because of decrease in the airway number and reduction in the lung tissue, therefore there is airway smooth muscle dysregulation and decreased lung volume. All these factors lead to an increase in pulmonary vascular resistance with risk of right heart failure. Now, when in most of the thoracoscopic or thoracic surgeries, the patient is placed in the lateral decubitus position. Now, the effect of this lateral decubitus position is similar for adults as well as in the children. In the dependent lung, because of the compression of the lower lung, there will be a chances of collapse of the alveoli leading to atelectasis. On the other hand, in the upper lung, which is a diseased lung, you will introduce insufflate gas into the lungs, into the chest, or you will use one lung ventilation. In that context, there will be a collapse of that operative lung leading to atelectasis. Now, the result of this is that normally the hypoxic pulmonary vasoconstriction will divert the blood from the non-ventilated zones to the ventilated zones. However, under anesthesia, this hypoxic pulmonary vasoconstriction is depressed as well as by the administration of the vasodilating drugs. Now, because of the absence of the hypoxic pulmonary vasoconstriction, the VQ mismatch is much more under anesthesia. Now, there are certain differences between infants and older children and adults regarding the oxygenation. In adults, the oxygenation is better with the healthy lung dependent and the diseased lung non-dependent. However, in infants, the oxygenation is better with the healthy lung non-dependent. So the reason for this difference is that children have soft, easily compressible rib cage. The FRC is closer to the residual volume, so that airway closure occurs in the dependent lung during normal tidal volume breathing. Now, in an adult, when you give a muscle relaxant, the diaphragm, which is in the lower lung, produces a positive hydrostatic pressure because of the abdominal contents, and because of this large abdominal hydrostatic pressure gradient, oxygenation is maintained. However, in children, because of a small rib cage, there is a reduced hydrostatic pressure gradient, and this prevents the favorable increase in perfusion to the dependent ventilated lung. Now, in cases of neonates, the one lung ventilation can be performed with a Fogarty embolectomy catheter, 3 or 4 French, and usually since double lumen tubes of the requisite site are not available for neonates. A Mararo DLT is available, however, it is not marketed and therefore very difficult to obtain. One lung ventilation obliterates the hypoxic pulmonary vasoconstriction. It decreases venous return, stroke volume, and therefore hyperreduces hypotension. In extreme circumstances, it can lead to tension pneumothorax, a mediastinal shift, and cardiac tamponade. The gas insufflation activates the pulmonary stretch receptors, increasing the vagal tone and producing bradycardia. The child should be preoperatively assessed by history and physical examination to rule out associated conditions. Lab investigations should be done based on the requirement and the diagnosis of the child. You should do a hemoglobin, hematocrit, kidney function tests. Their blood should always be available because the surgery is usually performed in neonates, and also because the chances of injury to the vessels is always present. If the child is having tracheophyseal fistula, one should perform an echocardiogram because these children have more chances of having an associated congenital heart disease. We should also look into the need for postoperative ventilation. Anesthesia is usually a balanced anesthesia with controlled ventilation using microcuff tubes This is cuff tubes are very important because these will prevent the leakage of gases around the endotracheal tube, leading to a decrease in the tidal volume being delivered to the patient and attaining sufficient peak inspiratory pressures. Nitrous oxide should be avoided. Air oxygen mixture is used. In this context, isoflurane is preferred because this inhalational agent has the least effect on HPV. The nasogastric tube should be passed, except in TEF, where you will not be able to pass it completely. The intrathoracic pressure should be kept between 4 to 6 millimeters of mercury to prevent significant cardiovascular compromise. The insufflation pressure should be limited to 4 millimeters of mercury, and you should create an artificial pneumothorax very slowly at the rate of 1 liter per minute, and you can optimize the cardiovascular function by using fluids and inotropes. The IV line should be secured in the upper limb. It is better to use an arterial line to measure the blood gases and blood pressure, also to do blood pressure monitoring in small neonates. CVP is not mandatory. If required, it should be placed on the side of the thoracoscopy to avoid bilateral pneumothoraces. When you want to perform a one lung ventilation, you have to place the Fogarty into the right main stem bronchus. For this, you should first introduce a bronchoscope, and you should try to place the Fogarty into the right main bronchus under vision. You should place it in such a way that when you inflate the cuff of the Fogarty, it should be just visible below the right main stem bronchus. And once you have confirmed the position of the Fogarty, you should place an endotracheal tube mid-trachea and start with the surgery. Now, what should be our strategy for intraoperative ventilation? The strategy should be to maintain the normal functional residual capacity either by using a pressure controlled ventilation or volume targeted ventilation with PEEP, because PEEP will improve the oxygenation. To facilitate carbon dioxide removal, you have to increase the minute ventilation by 20%. To ensure normo or mild hypercapnia, adjust the respiratory rate between 30 to 60. You should target a saturation of about 90 to 95% in a preterm and 94 to 98 for term infants. However, in most of the thoracoscopic surgeries, intermittent manual ventilation is required for managing desaturation and hypercapnia. One should measure the ECG, NIBP, IBP, SpO2 both pre and post-ductal, EtCO2 and temperature. Exhaled tidal volume, MAC and end tidal anesthetic concentration measurement is also important. EtCO2 is usually inaccurate during thoracoscopic procedures because of alterations in the dead space and shunt fractions, especially if you are doing one lung ventilation. Therefore, transcutaneous carbon dioxide monitoring is better and more reliable. Post-operatively, the child should be conscious with intact reflexes. He should be monitored for vitals and pain. If you have done a fundoplication, you should do an X-ray chest to rule out the possibility of the presence of pneumothorax. For pain management, you should do a local anesthetic infiltration at the site, administer paracetamol. One can also use thoracic and lumbar epidurals and erector spinae block. For PONV, administer ondansetron and dexamethasone. Therefore, thoracoscopic surgery in neonates is challenging. Main problems relate to hypoxia and hypercarbia. These may be worsened by one lung ventilation and lateral decubitus position. Neonatal lung physiology is also a contributing factor. Therefore, anesthesia for these children requires expertise and experience. Thank you very much.